Once I finish. Once I'm done. Good morning, everyone. Like I said yesterday, from today for the next 2 weeks, we have one of my very best students in medical school, Dr. Ravi Dadlani. He says that he liked neuroscience so much that he went on further to go dig into the brain and called himself the neurosurgeon. Okay, so and I found that he has done a lot of surgeries on brainstem, cerebellum, and of course gone to the cortex as well, but quite a lot in brainstem and all that areas. So I thought he would be the best person to talk to us about the brainstem. So here is Dr. Dadlani. And he and I are working as a team. If you have any questions during the lecture, after the lecture, feel free. He's always available. Okay? So please relax, enjoy the brainstem.
Thank you, Dr. Ulal. Can you hear me? Everyone, can you hear? It's okay? No? Get it up? Okay. It's almost max now. Is it better? Yeah? I'll speak up a little bit. So good morning to all of you. My name's Ravi Dadlani. You can just call me Ravi. I'm a neurosurgeon, and like Dr. Ulal said, I was one of his students. I always wanted to be a neurosurgeon, but I think I made that decision after working with him. So I had my first research project with him, my first paper published with him, and my first platform presentation was with him. So we go back a long way, maybe 20 years, right? So I've been a practicing neurosurgeon almost 15 years now. And I think, academic training is also a very important part of that. So I have been teaching, I've been training neurosurgeons and at the undergraduate level. So Dr. Ulal invited me here, and I was really happy to be here. So hopefully, I can share some interesting stuff with you guys. Now, what we're going to do with, I have a series of lectures planned. We're going to start with an introduction to the brainstem. And that's what we're going to do today, and look at some of the important external features of the brainstem. Now, so these are the learning objectives. We're going to look at some of an overview of the brainstem anatomy, brainstem organization, a little bit of that. We should be, by the end of the class, able to identify some gross features on the brainstem. So when you look at it, you can identify certain anatomical structures, which you can look at the brainstem and know what that is. A little bit on the cranial nerves. We're going to have different sessions on the cranial nerves. So a little bit about that today. And we get familiarized with the different divisions of the brainstem and what are their various functions in brief. Yeah. Now, the brainstem is very intimidating. I've always found that students at different levels have always found it very scary, very intimidating. And one of the reasons is that it is a complex structure. But if you approach it in a very systematic manner, it becomes a real fun process to learn about the brainstem. So the brainstem is, I'm sure you all have had classes on embryology, and you know that the brain embryology is quite complex. It develops from, none of this is going to be, this is not part of the main talk. So it's just an introduction. We'll come to the actual stuff in a few slides. So 3 basic vesicles or little sacs of the brain in the embryo, which gets further divided into different divisions. Now the brainstem is formed from 3 parts. You have the midbrain forming from the mesencephalon vesicle, and the mesencephalon forms the cerebellum and the pons. And then you have the myelencephalon. So it's a very complex embryology. And if you look at the way the brain folds onto itself, that is also very complex. And while that all is happening, you have a lot of complex features, a lot of nuclei and all developing there. So that's where the complexity of the brainstem begins. Now, if you look at it structurally, it's at the threshold between the brain and the spinal cord, 2 very different organs. And all the tracts of the brain and the spinal cord actually pass through the brainstem. So it has to have a capacity to deal with both of these things. And it's like an intermediate between them. So functionally and structurally, it's very different from the brain and from the spinal cord. It's the only part of the central nervous system which actually has connections with, motor and sensory connections with all parts of the nervous system. that includes the central nervous system, the peripheral nervous system, and the autonomic nervous system. It does not only relay, I'm so sorry, get back to this. It does not only relay information or tracks, it also modulates. So you've had classes on vision, but you know that the eye movements are completely modulated by the brainstem. We'll look at some of that in a later class. So it doesn't just relay information, it also modulates it and changes it a little bit. And like the brain, any part of the brain, the physiology and the intricacies of the brainstem aren't completely understood. And that holds true for the whole of medicine, I think. We're expanding our knowledge on a daily basis. So, but this part makes it more complex because there's new stuff, new information coming out every day. Now, if you look at the neurophysiology of the brainstem, there are three important functions that it has. We just touched upon this a little bit. So it transits or relays information. It does some amount of processing. That's with the cranial nerves and other stuff. What's important, what's interesting is the range of functions that it has. So if you look at any part of the nervous system, it generally is very specialized for one function. But the brainstem is unusual. It deals with vision, it deals with hearing, deals with a lot of other visceral functions. It deals with motor, sensory, everything. It also deals with things like respiration, your cardiovascular function, and consciousness and sleep-wake cycles. So that's a lot of stuff that's going on there. And therefore, you have different parts of the brainstem specialized for different functions. That makes it also complex. And the third important function is the cranial nerves. So a lot of cranial nerves, we have 12 cranial nerves, yes? And we have 10 of those which arise from the brainstem. So you've had classes on the other two, right? And who can tell me what are the other two cranial nerves which don't arise from the brainstem? Yes, so the visual and the olfaction. Yeah. So we have 10 cranial nerves, all with different functions arising from the brainstem. So these are the three basic neurophysiological functions. So just looking at how complex it is, I just put this up to give you an idea. There's almost no part or no function of the body which is not affected in some way by the brainstem. And I've often been asked by students, what role does it have, say, for example, in the genitourinary system? And if you look at the brainstem, it has complex functions, complex loops of neurons which go and regulate something like this. So you could have a brain tumor in the brainstem which can affect a bladder function in a patient. So very remote effects that it can have. Of course, you don't need to know all of this, but it's just an overview to give you an idea of why the brainstem can be a scary place to go. Now, as a neurosurgeon, yes, we both love and hate the brainstem, and for different reasons. First, I'll tell you why we hate it. Because the anatomy is so difficult to navigate. It's very complex, and if you look at the brainstem from a surgeon's point of view, there are very few areas where we can safely enter into the brainstem. For example, to remove a tumor, and they're called safe entry zones, and very few of those have been described. Now, when we do that, we do this with gigantic microscopes and things like that. So we're using cutting-edge technology to do that. But even with that, the morbidity and mortality is extremely high. So many of these patients, even with very precise surgery, do not do well. So that's another problem with the brainstem. There is no scope for error. Like when we do surgeries on the frontal lobe, for example, you can chop off a little bit and nothing, you don't expect any problems with the patient. You can't do that with the brainstem. Or with the intestines, for example, you can take off another 2 centimeters for a tumor or something. You cannot do that. You have to have millimetric precision. And the approaches are very difficult because the brainstem is in the center of the skull. And so the way to approach it, you have to go through a lot of structures to get there. So this is the reason why we hate it. Why we love the brainstem. So if you look at clinical neurology, one of the interesting aspects of clinical neurology is to be able to localize a lesion based on the signs and symptoms that a patient comes to you with. And I think the brainstem is one of the most precise places where you have something like a grid where you can pinpoint, with pinpoint accuracy, you can identify where the tumor is or the lesion or the stroke. And you can identify that on a clinical basis. There are very few parts of the nervous system where you can do that. why we love the brainstem is because of the anatomy. And I've put in some images here to show you that it's beautiful anatomy. I really like operating near the brainstem, in and around. You can see cranial nerves, you can see all the arteries, you can see different parts of the brain. It's beautiful, beautiful anatomy. Another reason why we like the brainstem is because pathology in the brainstem is rare. That's why I like it. Because if you look at all the problems that we have with the brainstem, I don't want to be operating a brainstem every day. Yeah? So it's extremely rare. Less than 5% of all diseases of the brain occur in the brainstem. So you see a few patients once a year or something like that. Rare cases. So that's good. We don't want to see too many of those. So having said that as an introduction, we'll come to some of the interesting external features of the brainstem. So I'm sure you're already familiar that the brainstem is divided into or classified into 3 different parts. You have the midbrain, the pons, and the medulla. The midbrain is the uppermost part of the brainstem, the pons, the middle one, and medulla, the lower one. Now, each one of these has got certain structures which are essential for you to know, both as external features and little nuclei or little centers which are within the brainstem. Now, we're going to look at this separately. We'll see some of the features today, and then we'll see some on sectional anatomy in later classes. What I wanted to stress here is that of the 10 cranial nerves, you have 2 which arise from the midbrain, 4 from the pons, and 4 from the medulla. So just to give you a bit of an idea of what a brainstem looks like on an MRI. Now, this is a section of the MRI which is taken, right through the center of the head. It's a mid-sagittal section. And if you look at the CSF here, it looks black in color. So you can see all the CSF here. So this is a T1 weighted image. A T1 weighted image is very good to study anatomy. There are certain changes which come in T2 and other images which makes it a little difficult to understand the anatomy. T1 is the best. Now, if you look at it, I'll just try and delineate this. So you have that part as the midbrain. Okay. Now, it's not just that. You have this tiny little bit at the back of the CSF space there, which is also part of the midbrain. And this is the this is special to the midbrain. It has bits of it which are anterior or in front of the CSF space, which is the cerebral aqueduct, and it's also there behind. You don't see that in the pons, and you don't see that in the medulla so much. So the pons is just this bit. You don't go into the cerebellum. You have the 4th ventricle there and the cerebellum. So this is something which is very special to the midbrain. That's the pons, and that's the medulla. Now, now that you know what the brainstem looks like on an MRI, I put this up with 3 different images. So this is a normal MRI, and these 2, the 2nd and 3rd images, are abnormal. Now, just to demonstrate something as simple as basic measurements in neuroradiology, we need to know how big a particular part is. You guys don't need to know this at this stage. You don't concentrate on any of these measurements that are there here. All right? But for a neuroradiologist and for a neurosurgeon, this is important information. Now, you can see that this is a normal brainstem, but look at what's happening here. And just visually, without the measurements, you can see that it's much enlarged. Now, this is an MRI of a patient having a brain tumor. And sometimes low-grade brain tumors cannot be distinguished from the normal brain, even on an MRI. It can just expand the brain without looking very different from it. So that's how we know that it's a diffuse tumor of the brainstem. And if you look at the 3rd image, this is the brainstem looks really shrunken and narrow. And this is a case of a degeneration, cerebello-pontine degeneration case, which is dealt with by the neurologist. Now, talking about the external features, external surface of the brainstem, what is important to understand here is that the brain is oriented horizontally. Yes, so you have the anterior and the posterior parts, but the brainstem is oriented vertically. Yes, so it forms this kind of an angle. So a lot of the brainstem stuff is more superior and inferior And we look at that when we look at the brainstem vasculature, the vessels. But when you look at the brainstem from the front, you're actually looking at the brain from the inferior aspect. So the ventral surface of the brainstem, you're looking at the inferior aspect of the rest of the brain. Now, when you do that, you can see that you can see all the cranial nerves that are present on the brain, except the fourth cranial nerve, which actually, the trochlear nerve, which winds around the brainstem, and it doesn't come out in the anterior surface or the ventral surface. Now, there are five of the cranial nerves, which are located close to the midline. So you know the first two is olfactory and the olfaction and the visual pathway. Those are located close to the midline. But there are three other nerves which arise from the brainstem, which are again close to the midline. Now, why this is important is because the brainstem shares some of the features of the spinal cord. You saw that on yesterday's review lecture as well, that the motor elements are all anteriorly and close to the midline, and the sensory areas are posterior. Some of that is carried on into the brainstem. So you have three cranial nerves: the oculomotor, that's here, the abducens, that's here, and the hypoglossal, that's here. These three cranial nerves are purely motor. You can have three types of cranial nerves. You can have motor cranial nerves, you can have completely sensory, and then you can have mixed cranial nerves, which subserves both the functions. Now, the motor cranial nerves are very close to the midline. And I put a little mnemonic here, so you guys can, those of you who can see this, it's a bit of simple mathematics, and you can remember that 3, 6, and 12 are the numbers of the cranial nerves which are purely motor, and they lie very close to the midline. We're going to look at each part of the brainstem a little bit more in detail. This is the midbrain. We start with the midbrain. The midbrain basically is called the mesencephalon. Meson, it comes from Greek. Mesos means the middle section. Encephalos means the brain. So you're going to hear the word encephalos a lot in neurology. So it's the midbrain, the mid portion of the brain, literally. And it extends from just below the thalamus to the pons. So this section is basically the midbrain. Yes? And I've given, for each of these sections, I've given a little bit of a generalized, a concise thing at the relations on the side. And the ones that are highlighted is something that you need to absolutely know. Okay? So it's the uppermost part of the brainstem. It's the smallest part of the brainstem. It extends from the thalamus to pons. It has a cavity. So each part of the brainstem is associated with a CSF-containing cavity. The first one is called the aqueduct of Sylvius, which is a very narrow part, and we'll look at it a bit more in detail later. And the other interesting thing about the brainstem is if you look at it longitudinally or vertically, you can actually break it down into three parts. So you have the part which is behind the CSF cavity, which we call the roof. Okay? Now the midbrain, like we saw in the MRI, has got a very definite roof. Now that roof word comes from Latin, and it's called the tectum. So tectum is the roof area, which is behind the CSF space. And the front part, the anterior part, is called the basal part. Okay? So the basilar part, which is the crus cerebri, the cerebral peduncle. These are not cerebellar peduncles, which are different, which will be dealt with in the cerebellar lecture. But these are cerebral peduncles. These are extensions from the brain, basically a downward extension of the internal capsule, and it contains all the motor fibers as well as sensory fibers, and the corticobulbar fibers, the fibers which end on the cranial nerve nuclei. Each part of the brainstem is associated with one artery. Now, this is very important to know. Now, I think you'll have had a class on vasculature as well, right? So this is the superior cerebellar artery, which is in relation to the midbrain. And the arterial supply, the nutrition, the blood flow that the part of the brainstem receives is usually associated with that same artery because of the close anatomical proximity. The cranial nerves which are related to the midbrain are the third and fourth, and we will look at some of the functions, very basically vision, hearing, and sleep, wakeful, arousal, things like that, arousal patterns. Now, looking at the midbrain a little bit more in detail from the ventral or the anterior surface, you have about 5 important structures that I want you to see there. The first one would be the oculomotor nerve. We already identified that, and that's right here. Okay? It's located just medial to the cerebral peduncles. So these are the peduncles here. Okay? And this is the oculomotor nerve. We already discussed the cerebral peduncles a bit. Those are here. And then you have the mammillary bodies. I'm sure you've studied a little bit about the mammillary bodies. Anyone can tell me what part of the brain it belongs to anatomically? Yes. And physiologically, it has connections with the thalamus as well. Yeah. So it doesn't technically belong to the midbrain, but if you look at it visually from the external surface, it's a very important landmark because you can understand that the midbrain is just below the mammillary bodies. Okay? There are lots of notes that I've put up on the side. You don't need to know all of that. Just concentrate on this, on the bits that I stress. I think that's important for you guys. Now, very briefly, we'll touch on this. If you look at the undersurface of the brain, you have 2 areas which appear perforated. It's got little holes in it, and that's because there are little arteries which enter this region. So you have the anterior perforated substance, which is in close relation to the olfactory nerve, and you have in the midbrain the posterior perforated substance. This region, this rhomboid-shaped fossa, is called the interpeduncular fossa, and it's of anatomical interest because of the relationships of the various structures that lie there, and sometimes you get very specific tumors and diseases related to the interpeduncular fossa. So it's good to know a little bit about it, and it's bound by the cerebral peduncles on both sides, and it contains the mammillary bodies and parts of the pituitary gland. So you have the infundibulum and the tuber cinereum. We will not go into the details of that. Now, if you look at it laterally from the section point of view, where this anatomy is with respect to the ventricular system, so it forms the floor of the third ventricle. So if you look at this, it's very interesting to understand how this is. This is the third ventricle, this complex little cavity here, and then this is the posterior perforated substance and the mammillary bodies. And there are certain surgeries which we do endoscopically, which we need to fenestrate into this region. So this is very important landmark surgically. Yeah? But we won't go into the details of all that. Now, one last thing about the midbrain, it has very important relations to the circle of Willis. One of the important structures that come out from here, the third and the fourth cranial nerves, you can see the fourth one winding around the brainstem and coming out there. The basilar artery is in close relation to the pons, and near the midbrain is where, anterior to the midbrain is where it ends. And it ends by giving out 2 branches which are called the posterior cerebral arteries. So the basilar artery supplies the brain, which is superior, the cerebrum, and part of the cerebellum as well. So it gives out 4 branches, 2 just before it terminates, which are called the superior cerebellar arteries, and then you have the posterior cerebral arteries. Now these are the 4 last branches of the basilar artery, but in between these you have the oculomotor nerve which passes through and the trochlear nerve laterally. Now this has important implications which we'll discuss a little bit in one of the later classes. If you look at the brainstem from behind, the dorsal aspect of the brainstem, a few interesting features are you have these globular little structures which are called colliculi. Colliculi basically means an eminence, something that's popping out of the brain. And you have 4 of them. So you have 2 up on the upper side which are called superior colliculi, and then you have 2 on the inferior side which are called inferior colliculi. Now, superior colliculi are physiologically, they have links with the thalamus, the lateral geniculate body, and are part of the visual system. I'm sure you've had classes with Dr. Ulal on that, so I won't get into that. But to understand that these are important structures here. Now, how they connect with the thalamus is these little arm-like projections on the side, which are called brachii or brachium singular. brachium basically means an arm. So you have the brachial plexus here. Yes? So brachium comes from the word which means arm. So they're arm-like extensions which get into the thalamus. And these would have the connections with vision and auditory or hearing. And the final structure on the dorsal surface that is important is the trochlear nerve. So you have the trochlear nerve which comes out just inferior to the inferior colliculi and goes around, winds around the brainstem. Now, this trochlear nerve is very peculiar in many ways. One of the important ways it's peculiar from the other cranial nerves is it decussates or crosses over. So you have the left trochlear nerve going out to the right side and the right one going to the left. And this is very peculiar for this cranial nerve alone. I just briefly wanted to stress on this bit that the cavity of the midbrain, which is called the cerebral aqueduct, it has many names, but if you just remember the aqueduct, that's enough. That's sufficient. And that's here. And what it does is it connects the third ventricle to the fourth ventricle. So it's very important part of the circulatory system of the CSF. Now, what's important about it is it's also the narrowest part. So it can easily get occluded or blocked due to various reasons. And that's called aqueductal stenosis. And when that happens, you get a lot of buildup of CSF above into the third ventricle and lateral ventricles, which you can see in this MRI. Now, this is a T2 weighted MRI, so the CSF looks white. And that's the lateral ventricle. And you know that the lateral ventricle communicates with the third ventricle to the foramen of Monro, which is very widened here. And that's the third ventricle. And when you come down, you can see that's the aqueduct. And the aqueduct looks quite narrow. And there's a little dark band across it. So there's some obstruction there. And how do you know there's obstruction? Because the fourth ventricle looks normal in size. So this is a case of cerebral aqueductal stenosis causing hydrocephalus. And this patient would require some sort of a surgical procedure to get rid of that. Very briefly, the functions of the midbrain. Sorry. It's not. This is Maxim, actually. It's Max, yeah. Maybe I'll just readjust this. Go with the other one. Is this better? Can you hear me? Better? Yeah. Okay.
You have to hold your head like this.
Yeah. So, thank you for that. So, if you can't hear me, let me know. Okay. Very briefly, three important functions of the midbrain. You have the substantia nigra, which we'll look at. Very important part of the midbrain, which is associated with the basal ganglia and has an important role to play in Parkinson's disease. The other two we have already looked at, vision and hearing, right? So these are the three important functions of the midbrain. Let's go on to the next structure. We have the pons. Now the pons in Latin means a bridge. And if you see that it actually connects the medulla and the midbrain, so it acts like a bridge in the brainstem. It's easy to remember. It's the middle portion of the brainstem. It's also the largest, especially from side to side. It's very bulky. You have a large bulk over here, okay? And the cavity of the pons, the CSF cavity of the pons, is the fourth ventricle. The artery which lies in close relation to the pons is the basilar artery. And the basilar artery actually runs in the anterior groove on the front of the pons right there. And that's where it divides into the branches that we were mentioning, where the third nerve passes between the branches of the terminal branches of the basilar artery. The arterial supply mostly is from the basilar artery as well, and the cranial nerves which are related to the pons are the 5th, 6th, 7th, and 8th cranial nerves. Now, I'll show you something interesting here. We already know that the 6th cranial nerve is motor, and therefore it's medial. Now, if you look at the 8th cranial nerve, you can see that it lies very lateral. Yes? Now, the 8th cranial nerve is completely sensory. So it's following the basic rule, right? The motor nerves are more medial and anterior, and the sensory nerves are more laterally placed. And if you look at this fifth nerve, which is the largest cranial nerve, the trigeminal nerve, and if you look at the seventh nerve, both of these nerves are mixed components. So they have some motor, some sensory. And they lie in a position from medial to lateral in between these two nerves. So they're kind of following that rule. Yeah? A small little a bit of description here. This is called a cerebellopontine angle. Now, I just wanted to stress a little bit about this because of its clinical implications. This is on the anterior surface of the pons that you can see. That's the cerebellum that we are seeing it from the front. This is the pons, and these are the nerves that I just described. Yeah. Now, this angle, which you can also see here, the angle between the cerebellum and the pons, I don't know if you can appreciate it here, just about this bit here. Okay, it's called the cerebellopontine angle. And why is it so important? It's because of the cranial nerves which pass there, especially the seventh and the eighth cranial nerves. They go through the cerebellopontine angle into the inner ear cavity, and this is associated with a lot of tumors that occur in that region. So you have schwannomas, the vestibular schwannomas, which are very popular. Those occur in this region, and they are there's a lot of work and a lot of research, and I've done a lot of surgeries on these tumors. So it's important to know that you can have very large tumors which occur in that region. Yeah? On the dorsal surface of the pons from behind, if you look at the brain, you can't actually see the dorsal surface of the pons because it's hidden by the cerebellum. Yes? So to appreciate what the dorsal anatomy of the pons is, you need to remove the cerebellar hemispheres, and that's what's been done in this first image, which is a specimen, anatomical specimen of the brainstem, and this is the diagrammatic representation of the same. So the cerebellum's been removed, and you can see that part of it is retained here to give you an idea of what the anatomy looks like. So when you look at the pons from behind, you're actually looking at a region called as the floor of the fourth ventricle. So if you look at this rhomboid-shaped structure here, that's the fourth ventricle, and the back of the cerebellum, of the pons, is the floor of the fourth ventricle. It's called the floor of the fourth ventricle. Very important to remember that, and it's got very important structures there. I'm just going to highlight one or two, and you have. I think we'll go on to the next diagram for that. Just one little bit on the fourth ventricle. The fourth ventricle actually communicates with the subarachnoid space through three foramen. You have the a midline foramen that opens up somewhere here. Okay, that's called the foramen of Magendie, and then you have the foramen of Luschka on either sides. It's easy to remember. Luschka is L, and that's lateral, and Magendie is an M, and it's in the medial part. So that's easy to remember. Okay, these are very important foramen because they can sometimes get blocked and lead to hydrocephalus and other disease conditions. Yeah. So looking at the basic structure of the floor of the fourth ventricle, it looks a little complex, but you can identify many of these things when you actually look at a brainstem. And the most important thing to understand is that there's this median sulcus, a little groove that runs throughout the length of the pons. And on either side, you have what is called the facial colliculi. Colliculus, we know, is an eminence, a protrusion of the brain, and the facial colliculus is related to the facial nerve, cranial nerve. Okay? It's also related to the abducens nerve. We'll look at that a little bit in detail when we do the transverse sections. The functions of the pons, obviously, it subserves the functions of the four cranial nerves, so sensations of the face from the trigeminal, some amount of eye movements with the abducens nerve, the facial movement by the facial nerve, and the vestibular cochlea, which is hearing. So it subserves those functions. It also has important functions in respiration. You have certain pontine areas which control breathing. And another important function is related to pontine nuclei. These are relay nuclei which form a part of the cerebral pontine cerebellar system. Now, I won't get into the details of that. I think that will be covered in the cerebellar lesson. But it forms very important nuclei, and that's part of that is what gives the bulk to the pons. The medulla, the last part of the brainstem, it's the lowermost section. It extends from the pons to the spinal cord. Again, the cavity of the medulla is the fourth ventricle, the lower part of the fourth ventricle. The basal part or the floor is the medullary pyramids, and this was, I think, also stressed yesterday in the review class where you have the pyramids there. The arterial relationship is the vertebral arteries before they join to form the basilar. So the vertebral arteries run on either side of the brainstem there. Okay, and the cranial nerves that it's related to are the last four cranial nerves. So 9th, 10th, 11th, and 12th. Some of it has motor functions, but most of them have visceral functions, including swallowing, taste, and different functions with the gut. Yeah? The ventral surface, or the anterior surface of the medulla, again, just a few of these important to remember. You have a median fissure on the front that extends and continuous with the fissure on the spinal cord. You have the medullary pyramids, which are part of the corticospinal tract, where the decussation or the crossing over of the motor fibers occur. And you have the olivary bodies. Yes, the olivary bodies are these lateral eminences just on the off the midline. And between the medullary pyramids and the olivary bodies, you have these number of rootlets which come out, join together and form the hypoglossal nerve. Remember, that's the motor nerve, so it's very close to the midline. And then laterally, or behind the olive, you have the lower cranial nerve. So you have the glossopharyngeal, the vagus, and the accessory nerve, the cranial root of the accessory nerve. Okay. Yes, the posterior, the dorsal aspect of the medulla, again, there are a lot of intricate structures there, but you don't need to know all of this. You need to know a few important aspects. You need to know the fact that there are two eminences over here, and this was also discussed in yesterday's class, review class, on the dorsal nuclei, the nucleus gracilis and the nucleus cuneatus. And the projections out from these nuclei are called tubercles, similar to colliculi, but they're bigger and more slender. So you can see those on the external surface of the medulla right here. So the functions of the medulla. So as you come down the brain stem, the functions become more and more visceral to do with the lower part of the body. So you have respiratory control, you have cardiovascular control, you have some vasomotor centers which work with the baroreceptors, and one very important part of the medulla, which is called area postrema, which is the vomiting center of the brain. Now, it's important to remember that a lot of the brain diseases, a lot of the syndromes present with vomiting. And you have at least two reasons why you can get intractable vomiting. Intractable vomiting is that where no matter what you give to the patient, the vomiting doesn't stop. They have continuous nausea and vomiting. It's impossible for them to eat or drink. And one of the reasons is because of pressure on the vomiting center. That's somewhere around here at the apex over here. Okay? So what happens is in two situations you can have intractable vomiting. One, when the pressure of the brain is really high and it presses on the vomiting center. And the second reason is when you can have tumors in this region from the brain stem or the cerebellum which press on the vomiting center. Yeah? This is a cerebellar peduncles. Again, it will be covered in the cerebellar class by Dr. Ulal. All I wanted to stress here that you have three cerebellar peduncles. Each one is associated with one part of the brainstem. So you have the superior, the middle, and the inferior cerebellar peduncles, and they connect with the cerebellum posteriorly. But when you see them, they all look like they are joined together to form one big bulky mass on the lateral aspects of the fourth ventricle. And because of that, it appears like they're all arising from the pons. But you have bits from the midbrain, the pons, and the medulla that come together here. okay? And it forms the lateral boundary of the fourth ventricle. That's important to remember. Okay, so yeah. So the vascular relationships of the brainstem. Very briefly, I'm going to tell you this. Don't let this, let the number of arteries or the labels here look intimidating to you. You need to just basically understand a few important aspects of this. These are the two vertebral arteries, right? They come together and they join to form the basilar artery, which extends along the length of the pons and bifurcates into the posterior cerebral arteries there and the superior cerebellar arteries, okay? And in between those, you have the oculomotor and the trochlear nerves which come out. Now, what's very important to understand here and how this vasculature differs from the brain vasculature. Now, remember when we were talking initially about the orientation of the brainstem, I said that the brain is located horizontally. So the blood supply to the brain, you have three arteries, right? The anterior, middle, and the posterior arteries. But when you look at the brain stem and the cerebellum, that changes because the perspective is more vertical. So you have a superior artery and two inferior arteries. That's important to remember, okay? And so you have the superior, although this is the posterior cerebral artery, just below that is the superior cerebellar artery, okay? And then you have the two inferior cerebellar arteries, which is the anterior, which arises from the basilar artery, and then you have the posterior inferior cerebellar artery. That's here. The posterior inferior cerebellar artery arises from the vertebral artery, not from the basilar. And the other two arise from the basilar. Yes? So it's superior and inferior, and for the brain, it's anterior and posterior. Okay? This slide I just put up to give you a view of what the brainstem actually is related to. Now, these are dural structures. It's part of the dura. You know that the dura is one of the coverings of the brain. But you have dura which lines the base of the brain as well, okay? And you have, you know what the tentorium cerebelli is. It's a partition which is also formed from the dura, which separates the cerebrum from the cerebellum and the brainstem. And that forms a little notch over here, which is called the incisura. It's here, and it's a very sharp-edged notch, okay? Now, the temporal lobe sits in this region here, and the brainstem passes through that. So it's a very tight squeeze, and there's really very little space or very little room for anything like edema or swelling that can happen in the brainstem without causing consequences. So you can have a problem in the cerebrum, and there's a lot of scope for developing edema or swelling, but you cannot have that in the brainstem because there's no room. Yes? And the temporal lobe that lies here has the mesial temporal part, which is called the uncus, right about there. And when you have, in cases of trauma or tumors, when the brain pressure goes very high, you can have what is called the uncal herniation. The uncus just tips over the tentorium there, and you have the third nerve which passes just below that. So that's because of that you get the pupillary asymmetry in these patients. And that's a very bad prognostic sign. You need to do something very quickly for these patients, otherwise you lose the patient. Yeah? Now, when the basal dura is removed here, what you see here is the foramen magnum, which is all formed by the occipital bone, the anterior and the posterior part, and that's where the medulla ends and the spinal cord begins. Again, a very, very small region with very little scope for any kind of problem that can occur there. Very briefly, we don't go into this. This is the complex part of the brainstem, which is still not very well defined. It's called the reticular formation, but because it's so important, I just wanted to mention a few things about it. It's this widely distributed little nuclei that occur all throughout the brainstem. So you have that in the midbrain here, the pons, and the medulla. And they subserve very important functions. In fact, you have consciousness, general arousal. So when you wake up a patient shining a torch in their flashlight in their eyes, you know, and the patient wakes up, that's happening in the reticular formation. Noise. Now, what happens when these areas get damaged, the reticular formation, in any way? You can have trauma, you can have infections, any of that, just involving the reticular formation and no other part of the brain can lead to a comatose patient. And that has very bad prognosis. So it's a very diffuse part of the brainstem, which we will not go into the details of, but it's also very, very important part. And finally, the role of brainstem in consciousness. So you know that what makes us human is the cerebral cortex, right? That's what really differs from species to species, and that's what makes an individual brain more interesting than the other. Now, if you have a lesion at the cerebral cortex, you can go into a condition called as a vegetative state, where you have all the primitive reflexes. So a person could be eating or chewing and breathing and everything, but he is not aware of himself or of others as a human. Okay? So this is a vegetative state now. The reason I put this up is because if you have a lesion in the brainstem, this is a condition called as brain death. And what that means, this is one of the criteria for having to, you know, in important issues like euthanasia or disconnecting a patient from a ventilator. Some countries allow that and some don't. There are a lot of medical, legal, and ethical issues with that. There's a lot of controversy going on about that. But one of the ways to decide if a patient is going to recover or not is to look at the functions of the brainstem. And one of the criteria used is something that's called brain death. So if the patient looks like he's in brain death state, you know, some countries and some laws would allow you for euthanasia or to disconnect a bad patient from a ventilator. So this is important to know. We won't get into the details of that again. And so that's it. Thank you. Questions?
You have a tumor or something at the floor of the fourth ventricle, and a neurosurgeon wants to get rid of the tumor surgically. How do you think he should approach? What is interfering? Cerebellum. So how would you do that? You cut the cerebellum? So now Dr. Dadlani will tell us what he does.
Yeah. So in neurosurgery, there's an interesting concept which we call an approach to a lesion. So even if the tumor is in the frontal part or the parietal part, there are different ways to approach the tumor. You have different approaches from the skin, the bone, as well as the brain. Now, where we enter the brain, that's really important because you have vital structures in there, right? So you want to do as little damage as possible. Now, for the cerebellum, we have the middle section, which is called the vermis, and the back of the cerebellum actually hangs down. And when it does that, the vermis is much higher, and you have a part of the cerebellum called the tonsils, which just hang down like that. And what you can do is just kind of put on a retractor, a special instrument, and lift that up, and you can see the foramen of Magendie. It's as simple as that. But if you have a tumor which is in the fourth ventricle, and I've done a lot of those, what we do is section the cerebellar vermis a little bit. We cut it, and that gives us access to the tumor. Yeah, so not the best way to do things, but then that's the limit of neurosurgery. Yeah, and usually people aren't symptomatic for that, except very small children who can develop problems with that. But usually the body recovers and the cerebellum recovers, and post-operatively they're fine, they're walking around, they don't have any visible symptoms from that procedure.
I have one more question. Okay. All right. Not question, actually comment.
Sure.
You're saying that approaching brainstem areas surgically is quite intimidating because it's a small area, you've got vital centers, you've got blood supply, the blood vessels there, you want to reach that area surgically. And you also were telling me yesterday that arteriovenous malformations are very common, quite common in brainstem. So that being said, what other techniques do neurosurgeons use besides surgery? in
Yes.
most of the brainstem
Yeah.
situations.
So in one of the slides, I had put that actually, but I didn't want to stress too much on that. Conditions like arteriovenous malformations of the brainstem. Now, these are conditions which occur everywhere in the brain. And I've worked with one of the best neurosurgeons in the world who's done over 4,500 of these operations. And he's a professor and all that. But when he would look at a brainstem arteriovenous malformation, he'd say, oh, we can't touch this. Yes. The reason is because it's so complex. And then we have things like radiotherapy and specialized radiotherapy, which are very focused radiations, which can be used in these patients. A similar thing would be tumors of the brain. Now we have what is called gliomas, which are the commonest brain tumors, and those can occur in the brainstem. Now, whenever we send a patient for radiotherapy who has a tumor, we need to do a biopsy and prove what kind of tumor it is, and so the radiation oncologist has an idea of what kind of treatment to give. But when they occur in the brainstem, that's the only exception. We can look at the MRI and say this patient goes for radiotherapy. We don't have to biopsy it. And they are okay with that, the oncologists, because they know that it's difficult to biopsy a brainstem tumor. So they would give radiation without knowing exactly what kind of tumor, what grade of tumor it is. These are exceptions that we follow in practice because of the complexity of the brainstem.
Any more questions? Go to his office.
Thank you.